Most of you know me. I'm Tyler, nurse practitioner. It's great that you're going to PA school. You're sitting next to somebody who will advocate day in and day out for the advanced practitioner route. So today's kind of topic of discussion, spine surgery indications and decision making. I think I'm mostly going to hone in on decision making, if I may. Hey, what's up, man? Always got to have an icebreaker. I like icebreakers.
Make you say the word 19.
What do you mean?
I bet I can make you say the word 19.
Okay, you can try.
All right. What's 10 plus 10?
20.
Okay.
Oh,
What's
it's off a
20
little.
plus 20?
40.
Okay. What's 40 plus 40?
80.
Yes, 20.
70. 60.
60. All right. What is 60 plus 40?
100.
Okay. What's 100 minus 30?
70. Do you even know these answers?
Yeah, I know the answers. Okay, so what's 70 plus 20?
70 plus 20. 90.
Gotcha! Gotcha!
No, I didn't. I said 90.
Yeah, I gotcha.
How? I didn't say 19.
I am with all of you guys in this room. I think we've heard this before, haven't we? One of our, if I'm not mistaken, it was maybe Dr. Gary Edwards or Dr. Todd Pitts, maybe even Dr. John Edwards. There's no surgery like no surgery. So ultimately, I think the objective here is when a patient comes to our practice, most of us advanced practitioners are trying to convince ourselves why this patient needs surgery and have we truly exhausted all conservative treatment efforts. So keep that in mind as we go. Today's focus is more on the surgical side of things, but just wanted to make that disclaimer that we are on your side. We want to avoid the knife as much as possible. So the reason I chose this topic was for many reasons, but mostly because these are very common statements that I hear in my exam rooms dealing with patients. You know, I heard they can replace disc now. I was referred to you to discuss disc replacement surgery. What about a disc replacement? My neighbor had a disc replacement surgery and is doing great. So these are all things that we hear, and so I think looking out from the outside in, you would assume that everyone is a candidate for a disc replacement and that should be at the top of the list of our decision making. But what I want to discuss today is just some of the variations and some of the thought processes that occur inside the surgical practice when we're considering surgical intervention. This is just to highlight some historical facts. This is kind of indicating, and we're not getting into the different types of implants, that's not the objective of this, but this is just merely to show that different implants have gotten FDA approval, and you can kind of see where the cervical arthroplasties are capable of treating multiple levels, but realizing that not every implant can do more than one level, and the max you can do is 2 levels at a time. So there are some barriers when it comes to multi-level pathology. Other things that I thought were interesting on this, so the lumbar disc replacement was actually FDA approved before the cervical arthroplasty or cervical disc replacement. And yet we have seen over time the cervical arthroplasty really take off and get a lot of steam as far as application and the utility of it. And then you can see it was only as of 2020 that you were able to do more than one level when it came down to a lumbar disc replacement operation. So this is kind of a motto that I followed, good, better, best. I think it's used in the financial world, but has anyone heard this term, utilized it in any way, shape, or form? Good, better, best, right? So, and by the way, your participation is mandatory. This is mandatory fun time, all right? There's no getting around it. We'll get to some conversation here in a minute, but good, better, best. So when I talk to patients, the first thing that I am explaining to a patient is this: there is rarely a perfect surgical option. Rarely. It is very, very rare. What I try to get them to realize is there's usually a good, better, and best option, and that our goal is to try to find the best treatment option for that individual, whether it be surgery or not. And those are some challenging conversations that we have to have with our patients. And you'll kind of see as we go along here, but just keep that in mind. And then as a kind of just general overview, I don't know, most of you probably know how our practice is designed, but if you send a referral to us for a spine management consult, they are going to see one of us advanced practitioners before they see Dr. John Edwards. So they're going to come in, we're going to assess them, we're going to basically decide, do they have updated imaging, what's their conservative treatment look like, what are their symptoms, what does the imaging show, and then essentially we formulate a tentative surgical treatment plan. And then what happens from there is we present that case to Dr. Edwards, who then reviews the image, reviews our assessment and plan, and then decides, you're right, Tyler, or no, you're actually wrong on this one, I think we should do this. And what I love about that is the autonomy that it offers me. I am in no way a surgeon, I assist on surgeries, but it has been very unique being in this setting, being able to gain experience and utilize some problem solving and trying to figure out what is the best course of action. So I just wanted to give you some insight on that. So I thought we'd just start and please.
In that process, so you said like if you formulate the plan and Dr. Edwards reviews it and says yes or no, what if you look at the person and say you're not a surgical candidate? Does he still review it?
It's a great question, great question. So I run into this all the time. And anytime I'm meeting with a patient and I can get a sense that they are like questioning what I'm telling them, because it's going to happen, right? I'm not the surgeon. I'm not the one doing the surgery. I'm not the buck doesn't stop at me is what I like to say. So if I get any sense that a patient seems unhappy or is like a little bit concerned with my recommendation, I always tell them, look, I'll run this by Dr. Edwards. I'll have him look at it and confirm that what I'm telling you is actually what he would be telling you. So. And for my peers, you have to wait at least 30 seconds before answering because I really want to get these others involved, okay? 30 seconds of silence I can probably tolerate. So instead of giving you a case presentation, I'm going to start with the MRI. And what I would like us to do is try to just discern information from this MRI. So tell me what you guys see here. What are the things that you guys can appreciate on this particular MRI? And it's an MRI of the lumbar spine, the low back, just for starting point. And this is a side profile, and then this is actually the L5-S1 disc space here. There's no surgeons here. We can just say whatever we want. So it doesn't matter. It doesn't matter. Just tell me what you guys see. What do you guys see? David.
The other 5 vertebrae above it look white and pretty.
Oh yeah.
My technical term.
I love that, white and pretty.
It's nice to see that the bottom one looks messed up.
Yeah. So he's commenting on.
I'd see that, yeah.
Yeah. Degenerative disc disease, L5-S1. Everyone see that? It looks different than these other levels. What else do we see?
Is a central protrusion in L5-S1.
Great. So this little lobulated mass here is suspected to be disc material, which you can also appreciate right here on the scan.
And it does look like it may have extruded.
Extruded. So now we're categorizing the type of disc herniation, a disc extrusion. What else do you see? It's okay if you don't see anything, but
You see the dura being pushed
yep.
to the side.
Yep. So there's a nerve that rests in here that I think is definitely being deflected at the very least, if not impinged. So anything else? What do you think, Brandy? Anything?
That may just be the slice, but it almost looks like this patient's had a laminotomy before.
Bingo. So this is indication of a surgical defect, if you will. So these are post-surgical changes, rather. You're seeing where lamina has been removed. So this suggests the patient had a prior disc herniation and underwent a discectomy. So now we're dealing with a recurrent problem. So now with this in mind, what would you expect the patient to present with? Simple questions on that. Well, like what symptoms would they present with? Sorry, I should have clarified. Ridiculous symptoms.
I would say anywhere from diffuse low back pain to ridiculous symptoms.
So good, yeah. So probably low back pain, radiating pain going down their leg if this nerve is being affected, which it is. And then back to kind of assessment of the MRI, would you say, could you just look at this MRI and assess or assume, is this patient a healthy patient? Is it a young patient? Is it an old patient? What would your assessment be?
30s or 40s.
So we got a 30 to 40 guess. Anyone else agree with that? Everyone's shaking their head yes, so yeah. Yes, this patient's about a 36-year-old female. Underwent a discectomy, got sustained relief for a period of time, developed recurrent symptoms. Post-operative MRI came back, revealed that there was a recurrent disc herniation. So now, as the provider seeing this patient in the clinic, I'm left with deciding what are the treatment options. By the way, for the sake of this discussion, they have exhausted conservative management, okay? So physical therapy, injections, so on and so forth, okay? Please.
So just a question on this patient. Excuse me, a question on this patient. I mean, they've already had surgical intervention. How often do these, and it may just be teeing this question up, how often do these patients come in and just want to skip straight to surgery because they know it worked in the past? And they're coming in and you're like, okay, well, let's try PT and injections. They're like, why? I already know I have to have surgery because I did this before. That's got to be a tough road for you to put.
Yeah.
I know it is for us, but
It 100% is.
we see them after you've already talked them into it.
Yeah. That's a good point. Yeah. You're absolutely right. That's spot on. I think the most challenging conversations that we have is trying to get them to realize if it's, so this is according to Tyler, okay? If a patient comes in, has a discectomy, and let's say they come back with recurrent symptoms within 2 months, I think the argument there is there may have been remaining disc material that wasn't identified or that was on its way to herniating again, that's worth maybe going back in and re-exploring depending on the severity of the symptoms. However, every time a patient comes back to clinic with recurrent symptoms and we see something like this, we are having the conversation. We might want to consider a repeat round of conservative management, because I think at the end of the day, every disc herniation is going to respond differently. We never know. This one may actually settle down and over time reabsorb. So the conversation is always such that conservative treatment should be the first option. However, there are the patients who push back really hard that they really want to move forward with a repeat discectomy. So that's where it gets challenging. So in that same line of thinking, if you were the surgeon and you did a surgery and a patient comes back and has recurrent symptoms, what would you do? And they'd failed non-surgical treatment. What's the next best option?
In this case, you have a central protrusion, and so you could go back and do another discectomy, but since it is central, those are likely to reherniate.
So that now you're starting to think about these little nuances to disc herniations, the recurrent rate, the vulnerabilities and things like that. Exactly. So what other options?
So then you might want to move to a disc replacement or a fusion.
Okay, so he brought up disc replacement. So you got a young female. By the way, she's active military, so she's very active individual, stressing her spine repetitiously with some of the demands of her work. So these are things we're also considering as well. So immediately, who agrees a disc replacement? And it's okay if you don't know. Okay. So fast forward, Dr. Edwards reviewed it. Patient underwent a disc replacement. We didn't mention this. Might I just highlight this little thing right here? She had a prior SI joint fusion. So there is some other factors that we're considering in our decision-making process. The more we mobilize the spine, the more stress we're going to put on the adjacent segments. So keep that in mind. So this patient underwent the disc replacement and ended up doing really well. In fact, I think we're scheduled to see her at follow-up here pretty soon. Here's case number 2. Same thing. Let's tell me what you guys see. So this dotted line, this is a reference point to show you where we're at on the axial slice.
Doing great at L4, L5. That disc is nice and extruded and pressed out on the canal there.
That's exactly it.
It looks like this one also had a prior surgery.
Yes, they did. In fact, they had 2 surgeries. 2012, they underwent just a standard discectomy, and then they went back in and did a laminectomy, a secondary posterior decompression in 2021, I want to say. So about a decade apart, and then presented to our clinic with recurrent symptoms. So, patient has recurrent disc herniation. What do you suspect their symptoms are? Low back pain, radicular symptoms. The central canal, is it pretty open or is it closed off? This being the central canal, and I don't have a comparison. On another slide, I'll show you a comparison, but it's closed off. And then what else are we seeing on the facet joints?
Is that hypertrophy?
Hypertrophy. This white signal indicates there's fluid inside that joint or inflammatory changes, which can basically indicate that there's stress on that joint, gapping of the facet, potential hypermobility. Please.
This patient had persistent neurological stuff, like some underlying weakness that's left over from the first 2.
Yes, there was some residual symptoms, but nothing like after each surgery, the patient did really, really well. So clearly they're coming back like, you got to fix it. Like, I felt so good, but then the symptoms reoccurred.
However, with the facet, the multifidi look really good, so you're not having any medial branch affected. Where if there was an issue, then the medial branch would affect the multifidi, and that would start to have fatty infiltration.
So he's commenting on the paraspinal musculature, observing how much fatty infiltration is present. Which, if you see a lot of marbling back here, that suggests that you are losing muscle tone in the paraspinal, the multifidus muscle, which is your internal stabilizers, right? We need those to stabilize the joints. So, great observation. Anything else, please?
I would have to see some other slices, but it almost looks like they have some medially oriented pedicles and maybe some underlying, or like their central canal is more narrow than most people.
Great point. Yeah. So we're looking at all of these different factors when we look at an MRI. These little subtle changes might change our decision making. So with all of that in mind, and as us all acting as surgeons, what would you recommend from a surgical standpoint? Go back in and do another discectomy? Who says that? How about a disc replacement? Who says that? We got one. Disc replacement. Good. How about a lumbar fusion? Got some hands? All right. Well, the decision was to do a lumbar fusion. And actually, as I was putting this slide together, one thing I just looked at the angles, and I'm not sure why, I just kind of looked at it. I know why. I read in Dr. Edwards' op report, I did not assist on this surgery, but he had commented that the patient had loss of lumbar lordosis. And so I was actually intrigued to see that this is the pre-op MRI, 32 degrees of lumbar lordosis. This is just a really quick measurement, mind you. And then it went up to 42. So being able to restore lumbar lordosis. Can anyone explain why that would be important? Preservation of the lumbar curvature.
It's going to be a bit more protective of the levels above.
Yeah, it's going to help us equally distribute that weight bearing status. So one analogy, which is probably not a great analogy, but I talk to my patients about, is whenever I see a straight back, what I'm trying to explain to them is the vulnerabilities and the stress that's placed on the disc in that setting. So if I use the analogy of if I stacked up a bunch of quarters nice and neat, where is all the weight at? It's at that bottom quarter. If I step those quarters off just ever so slightly, I could take some of the stress off of that bottom segment. And that's the idea with trying to maintain or preserve the lumbar curvature of the spine, the lordosis. So we're always thinking about that as well. And Dr. Edwards was able to obtain some increase in the lumbar curvature by doing a lumbar fusion here. So here's the picture of the axial slices side by side. This is the disc replacement surgery. This is the lumbar fusion surgery. The question is, what is the difference? What was the difference here? Why did we choose a lumbar fusion in this case and a disc replacement in that case? Well, we already discussed some of the things that we're thinking about when we decide to do surgery, but here's one other thing that really is probably most important of all is the access. Does anyone know what these structures are here? Arteries, veins and arteries, large vessels that traverse right in front of the spine. So a patient comes in and says, I want a disc replacement. First thing we're looking at is their anatomy. Are you even a candidate for a disc replacement? Now, backing up a few slides, the FDA has approved from L3 down to S1, which means L3, L4 disc replacements have been done. L4, 5 disc replacements have been done. In fact, Dr. Edwards has done them. But what we've found is that the vessels are oftentimes in the way of us safely accessing the disc space, because when we do a disc replacement, we have an access surgeon, a general surgeon, or a vascular surgeon make an incision and move everything to the side and essentially gaining a line of sight to the disc space. So as you're pulling vessels aside, if you nick or tear a vessel, that's a bad day. We're very sensitive to when we are considering recommending a disc replacement surgery. And then here I just kind of showed you, in her case, you can see a perfect line of sight of where Dr. Edwards could go in, remove the disc, expose enough of the elements to be able to put the disc replacement midline. So that's another factor that we have to consider too, is the placement of the implant. If the placement of an implant is 1 millimeter off to the left or right, that could completely change the overall spinal biomechanics. So it's very crucial that we're pretty confident that he's going to get the right exposure and be able to place that implant midline. So things that we're considering when we're making these decisions. Here's just an example of an L4-5 disc level that was pathological, in which we elected to go ahead and do a disc replacement. You can see here the vessels are actually way out of the way, so our access point was wide open. And then this is just a schematic of the surrounding anatomy of the spine. Here's a situation where a patient has neuroforaminal stenosis. They have neck pain with radiating symptoms extending down their left upper extremity and failed non-surgical treatment. Perfect candidate for a disc replacement. Motion preservation surgery is the ideal. So anytime we can preserve motion, we're going to. Case 4, patient had a prior cervical fusion. Now we're seeing changes at the adjacent level. So not only is there disc bulging and central canal stenosis, but there's buckling of the backside of the joint, which a disc replacement, I like to tell patients, we're addressing a component of the joint. If you're mostly having disc pathology, a disc replacement makes sense. But if it's more involved than that and there's arthritis on the posterior elements, what we're essentially saying is we'll replace your disc and you'll still operate on an arthritic segment. And so that's where the rubber meets the road. Is that the best decision making for a patient and considerations that we are looking at? So in this case, because of the posterior involvement here, we elected to do a cervical fusion with the potential to go back in and do a posterior decompression. And I don't have a postoperative x-ray. Sometimes though, we get really creative and we do hybrids. So now we have 3 levels that were pathological and recommended surgery for, and we did a fusion and then put disc replacement surrounding that construct to, again, preserve and maintain as much motion as we can. Real quick, anterior versus posterior column pain, super important. I'm asking every patient, where is your pain? What makes your pain worse? Bending forward, extending back, those are all very crucial in the decision-making process. aggravating and alleviating factors, and then mechanical versus neuropathic. If a patient comes in and says, really it's just my back pain, I'm going to tell them I'd rather it be leg symptoms. That's easier to treat than back pain. Back pain is very complex. And again, going back to this good, better, best, there's not a perfect surgical treatment option for axial low back pain oftentimes, not every time. These are other considerations that we're looking at. Age. Some people will question, is age a factor in deciding on a disc replacement or not? The answer is no and yes. Some of the literature would suggest, obviously, as we age, there might be some underlying factors, bone density loss, facet arthritis changes, adjacent levels and things like that might deter us from doing a surgery. Body mass index, BMI is super important in our decision-making process. We like to keep patients under 40. And the literature even suggests that if a patient has an elevated BMI, even further should steer away from disc replacement because of the stress load it will put on an artificial implant and probably not yield the results you're looking for. And then all these others, and one of the most important things is, who believes that all health insurance plans cover arthroplasties? The answer is no, they don't. Some of them deem arthroplasties experimental, which puts a stop on our ability to do a disc replacement. Other treatment options, as you all would like to hear, stay active. That's what we're telling patients. Sedentary's not going to win over being active. I know it's painful, I know it hurts, but we got to find a way to keep you moving. That's going to help you more than anything else. Some interesting things that I found in my research, there's the FDA just recently approved a facet arthroplasty. So we talked about the concern of arthritis developing in the joints on the backside, preventing us from doing a disc replacement. Well, they are looking at ways that they can try to replace those arthritic joints in particular settings, still preserving motion and then providing stability. Of course, neuromodulation, where would I be if I didn't put a plug in for spinal cord stimulation as a means of managing pain, not treating the underlying problem. Keeping an individual active, that's the idea here. Basivertebral nerve ablation or Intracept is another procedure, particularly with axial low back pain, modic changes. So these are just a very few other treatment options that we're considering. My hope for today was just that you'd get some insights into what we do in our practice when a patient comes in for a surgical consultation, all of the things that we are considering when we recommend surgery, and the reason for recommending the type of surgery that we do. Thank you.